Today we're gonna follow up a little bit on the cervical techniques that we learned yesterday. We'll go through some of the foraminotomy, just a quick review, laminotomy, and then actually there's some advanced techniques such as laminoplasty, and then we'll go over some pearls and pitfalls and some conclusions. These are my disclosures. So yesterday we heard some outstanding talks and case presentations from our faculty, and it's a great start for learning the posterior cervical technique in endoscopic surgery. There's been many advances, and yesterday we learned a lot about these foraminal decompressions and disectomies, and the publications are becoming more and more high volume every day. It's like 15 or 20 years ago when I was sleeping on Tony Young's couch at his house, maybe there was 5 people doing endoscopic surgery in the United States, and no papers were published, nothing. Fast forward 10 years, now we're seeing 5 papers a day that are coming out of like Asia and US, Europe, all over the places. And now we're having comparative studies, which is even more amazing. So they're comparing different types of endoscopic techniques, uniportal, biportal, all these different things. And from the papers that I've been seeing and reading, all of the techniques that we're learning about here at the course are really showing really good outcomes overall. Whether it's uniportal or biportal, especially in the cervical spine where you can preserve more of the facet because of the fact you have a scope with an angle. In the traditional open discectomy, say even through a tube, you're taking more of a vertical cut of the facet, so you're taking more facet off. With the angled burrs and the angled scopes, you can take less facet, so you're destabilizing the spine even less. So yesterday we learned about the foraminal decompression, where we're taking off about 30 to 40% of the facet, allowing you to see the nerve, work around the nerve, and do your discectomy. Laminoforaminotomies, we need to see more of the spine. So this is what we saw a little bit yesterday. We could see the whole facet, and then you work medial to the laminar facet line and do your decompression. With the laminoforaminotomy, you've got to see the upper lamina, the whole distal lamina as well. So you're working more here up along the spinous process. The difference between foraminotomy and laminoforaminotomy is not just from an anatomical sense. It's also technique-wise. And so some of the principles we learned yesterday also pertain to the more advanced techniques. One of the biggest differences, I think, is that you really have to preserve the yellow ligament, the ligament inflavum, as long as possible. This permits you to safely decompress the spinal segment. So yesterday we saw a case similar to this. This was a case I had with a professional singer, and so we did a foraminotomy discectomy, right? But how about this patient with cervical OPLL, right? So you have a patient like this, which is different. So we can't just do a simple foraminal decompression on that patient if we're going to treat this endoscopically. So what's happening now is that people are making lateral troughs and medial troughs and lifting the whole lamina off using techniques. And so I'm going to show you some papers and articles. This is a emerging type of technology, endoscopic. It's not something that you'll do right away when you go home, right? There are still things that have to be worked out. The kinks have to be worked out, but I'll show you some papers and interesting techniques. So this is a paper that looked at OPLL, and they're taking off half of the lamina, so hemilaminectomies. They did 13 patients. This is a case report of a patient. They did an over-the-top technique. So yesterday there was some over-the-top people wanted to go, look into that, and so we did our foraminotomy just like this, and then we took more of the lamina off, and then we went over the top and we did some decompression. Some of us got a little too adventurous and did more of a decompression than they needed to, but this is the sort of the technique. Now this is not something that's being done on a frequent basis, right? These are case reports here and there, but again, this is sort of like evolving. One thing you have to be careful with here is that, see, the cannula is not really pushing into this other side of the lamina. It's just resting a little bit on top of the dura, but it's not actually going over the top of the dura. So in order to do this technique, that yellow ligament has to be preserved, right? You can't take a burr and burr the opposite side unless the yellow ligament's intact. So when you're doing this technique, the yellow ligament's got to stay preserved, whether using a burr or a kerrison or a combination thereof, because you can't take this cannula and press it on top of the spinal cord, obviously, right? Because then you're going to have problems neurologically. And so this is sort of the over-top technique that's being used. This is a case that showed a C2-3 area of stenosis. And then there's the biportal. This is the same case. Same group of people. Went from a case report to 30 patients. So they expanded their procedure. Then there's a paper that looks at full endoscopic laminotomy versus anterior cervical discectomy. So again, this is a retrospective, but it's a propensity score match study. So their conclusion was that the posterior full endoscopic decompression was just as efficacious as an anterior treatment. You see, so now we're getting pretty in depth with the cervical endoscopic techniques. Okay, so this is really going to stretch your brain. Laminoplasty, right? Can we do laminoplasty using endoscopic techniques? And the first case report came out looking at a mini plate, using a mini plate, and then a series of patients came out after that using a biportal endoscopic technique. And basically what they do is they come in, they create a trough on one side, so they use a uniportal or biportal technique. This is the hinge side, and then they go to the opposite side, they release the spinous process, create their open door corticotomy, and then lift this up and put a plate on. The plates put in, they actually connect the two incisions for their biportal on that opposite side, and they put the plate down. So it's kind of endoscopic, but it's also a little bit open. There is a surgeon that's doing it all endoscopically through the same portal, but it's really difficult. And from what I've seen, I don't know if it's gonna last that long, because it's just difficult to get the plate positioned. But with this technique, is they're lifting up 2 lamina, like 5 and 6 or 6 and 7. It's a minimal 2 lamina, right? And so to do that through a single portal is going to be very difficult. But they've outlined their whole technique. They've got a really specific methodology. This is sort of a video. I think we have a little time. I'll kind of run through this with you a little bit. So this is the side. They're cleaning off the lamina. This is interesting. I like this bipolar because it allows you to really dissect and push at the same time. I don't think we have one here, but some of the companies have these, and they're really nice. They're mainly used like in shoulders and for shoulder arthroscopy. So companies do have these. And so once he's cleaned off, the 2 lamina, so say this is 5 and 6, then they'll go ahead and they'll make their corticotomy for the hinge. So this is making the hinge on the, say, right-hand side, if you will. And it's a pretty wide space. That's a 3 millimeter burr. So they've done, say, C5, and then they'll do C6. So this is the second one. And so now the 2 hemicorticotomies are made. And then they're going to drill through this. So now they've switched sides. So now they're on the opposite side of the table. And so now they're base of the spinous process. And so now, because in order to hinge that lamina, either you release the interspinous ligaments, like between C4-5 and C6-7, which you really can't do endoscopically that easily, or you can just release the spinous process so that the lamina itself will float up, which I think is a pretty interesting adaptation. So they're going to drill right through the spinous process of C5, then they'll do the same thing at C6. Kind of fast forward just a little bit. So you see now they're getting through the opposite side. It's almost down there. So they've gotten through. This will be C6. Okay, so now they're through. So now you see the spinous process is floating away from the lamina, which is on the distal side. So now they're on the opposite side. They're going to go and make their full corticotomy. First, they start with their burr. They're going to finish it with their kerrison. So now they're working down in the C6. Forward this a little bit. And then now they'll take their kerrison and they're going to go ahead and cut through the remaining portion of that lamina. And then, like I said, what they do at the end is they'll connect their two incisions for their biportal on that one side, and then they'll place the two little plates, put a drain in and close it. So how many people have done like laminoplasties open? Right, so that's good. So, it looks very familiar to you, right? The burring, the kerrison work. I think what's really unique, though, is that whole idea of like releasing the spinous process, being able to elevate it up and over. It's something you can almost use like in an open technique if you think about it, right? Okay, so this is their post-operative X-ray, CT scan, and you can see the incision here. This is where they connected the two incisions, so they have a biportal on this side and a biportal on that side. They connected the two incisions, put the plate on, and then closed it up. So yesterday we talked about the foraminotomy, and I think it's critical to understand how to do a foraminotomy if you're going to do anything like laminotomies, because especially at C4-5, if you don't know how to do that, you've got to free that fifth nerve up so you don't get a palsy. So the principles that you learned yesterday are very important, for laminotomy or laminoplasty work if you're going to do them, because it's really critical to do that, I think. Positioning and setup, same exact stuff as we did yesterday, no difference in that. The equipment that you use is slightly different, I think, because you need to have more burr action. And I think right now in the U.S. we just are now available. We have bone scalpels. Do you guys have bone scalpels? Like you have Mycinex here, right? I think probably.
We've used them.
Yeah.
We don't have it.
Okay, so we have bone scalpels that we use for open surgery in the U.S. and now a Chinese company, I'll give you their name in a second, has developed a bone scalpel for endoscopic surgery. And so this is what that looks like. And I think if you're going to do these advanced cervical techniques like laminotomies, laminoplasties, things like that, it's good to have it. And this can also help with foraminotomies too, if you think about it. So it's very safe. It doesn't have anything that spins around. It's basically like a harmonic, right? So they're using harmonics to like pulverize and loosen, the tissue. And so if you think about like what we're doing in the foraminotomies and laminotomies, we're creating this sort of ledge, and then we're taking a kerrison and biting off the rest of the ledge. So you could do this very nicely with a bone scalpel. You could actually do the whole cut if you wanted to, and not have to use the kerrison at all. And there's you have also a sharper tip that you can actually, remove and release bone and make your trough using the scalpel itself. So the company is this company at the bottom here, SMTP. This is a Chinese company, and so they have distribution now in the U.S., and they actually have distribution in Europe too. I'll give you their contact. I think it's here. So this is the name of the European distributor for this bone scalpel. So I think it might be nice, maybe the next lab we do or something like that, we can have them come, and we could, use that, in the lab as well to further advance, our techniques and education. I'm not going to go through the step-by-step, guidelines again, because we did a lot of that yesterday. The same principles for setup, midline, mark off your medial pedicle line. I make a longitudinal incision in case we have to open up. Safely cut through the deep fascia, place your probe. You feel your, I place a little needle, but I don't go too deep with the needle, just so I know where I'm going. And then I learned this little technique from Rutan. He takes his little obturator, and just dissects and feels around for that V point before you even put the cannula down. You can know where the V point is right away just by palpating the V point with your obturator. It saves a lot of time, and you can do a little dissecting with the probe as well. So by the time you put your cannula down, you're all set to go. So this is the V point we were talking about, lamina, V point. There's your facet joint, so you've got to place your cannula, over that V point so you can see it. And then from there, once you have that, I start with the laminotomy first. Again, especially if I'm doing C4-5, because then that lets me go out from there. I know where the medial facet is. I know where the root is. I'll take the lamina, thin the lamina first, and the last thing we do is take the yellow ligament. So the yellow ligament stays as long as possible. And this just shows, taking that the inferior edge of the superior lamina, and then working distally down to your inferior articular process. Then you find your SAP. So this stuff we did yesterday in the lab, the same principles. And then from there, I like to use a hooded burr to complete most of the laminectomy stuff. Again, to protect the dura and to protect the yellow ligament, and to take the rest of the lamina off, and then use Kerasins for the last little bit as we showed before. And then in the end, you'll see the dura here, and you can take the rest of this ligament off, right, the yellow ligament. You've got your nerve down here, and all this can come off now because now you know where your nerve is. You have your edge of your thecal sac. You can take the rest of this lamina off over here if you wanted to. So that's the proximal nerve, distal nerve, lamina, yellow ligament, work medially. You've done your case. So it's very similar to a laminoforaminotomy, but you're just working a little bit more medial and distal. I like a pedicle view, so you've got to turn your camera 180 degrees to see both pedicles. Disc herniation we talked about yesterday. So, Elias, what do you see here on this series of pictures? Is this good, bad, or not so good? Or what do you think? What technique do you think? How would you critique this?
The problem is that you already took out the yellow ligament.
Bingo. Good job. He paid attention. One person. Excellent. So I don't like this, right? This is something that's published, right? And you can see what they've done is they've taken the yellow ligament off. The foraminotomy hasn't been done. And so now when you're doing your foraminotomy, all this dura is wide open. If your burr accidentally slips, if your Kerasin is in the wrong position, right? You've got a real problem. And so, I think doing this first and then working this way makes much more sense. So whenever you read things or look at papers and things, think of, be critical of what you're looking at and see if that really matches what, the real world is sort of telling you. Maybe sometimes you have to do this for some reason because you have a big overlying osteophyte like over the lamina and you can't reach your facet or something, something strange like that, but it's pretty infrequent that's going to happen, So in summary, posterior cervical techniques are rapidly evolving. The laminar facet shelf first, resect ligament and flavum last is sort of a guiding principle. We're going to start, you should start with lumbar procedures before you jump into cervical, doing laminar work and facet work. Don't jump into a big cervical complex case first. Start out from the lumbar spine and then work simply. Do foraminotomies first, then do laminotomies, and then maybe in the future, laminoplasty work. But take it step by step. So with that, I'll just say thank you for everybody for attending. And we're going to go into the lumbar procedure now, which is a great way to kind of learn this laminoplasty or laminectomy technique and then jump into the cervical stuff later on. All right, thanks for your time.